Well, good morning again, everyone. Thank you for joining us today. My name is Dr. Savannah Clary, and I am part of the clinical team at Aegis Sciences Corporation. Today's webinar will cover aspects of buprenorphine result interpretation. I ask that you please ensure that your phone is muted throughout the presentation, and at the end, I will invite you to unmute and ask questions if you would like to do so. If you would like to hear this presentation again, it will be available soon on our website at www.aegislabs.com. Under the Resources tab, go to the Events page and then click on the Recorded Webinars tab to find this recording, and we also have several other recordings there of our past webinars if you would like to check those out as well. Our objectives for today are to review available dosage forms of buprenorphine monoproducts and combination products, explain the period of detection for buprenorphine in urine, oral fluid, and blood, and some possible exceptions. We'll describe conditions that may affect the detection of buprenorphine, including the dosage form that's administered to the patient and the specimen type that is used for testing. We'll also discuss naloxone detection and considerations when interpreting these results alongside buprenorphine results. And we'll also evaluate unexpected buprenorphine results and possible clinical explanations for those results. Buprenorphine prescribing is very common across multiple clinical specialties, particularly those who treat opioid use disorder and those who treat pain management. Depending on the indication, there are various dosage forms that are available to help patients overcome adherence barriers and also provide different strategies and tools for patients and providers to work together to achieve the clinical goals. New legislation has recently opened the door to allow additional qualified practitioners to treat patients with opioid use disorder with buprenorphine. So some of you listening may be newer to testing for compliance with buprenorphine. Whether buprenorphine is prescribed or not, it is important that anyone ordering compliance testing for this medication be aware of the various clinical considerations when evaluating these results. Buprenorphine is available as a monoproduct, and it's also available as a combination product in some dosage forms with naloxone. Again, depending on the indication, it is available as a buccal film or a sublingual film. There are also some injection products that are available for a little bit longer action. Sublingual tablets are another option, and there are also transdermal films. Some of these products are indicated specifically for pain management, while others are indicated for opioid withdrawal and opioid use disorder. And also some of these products do have generic options available. The amount of time that buprenorphine may be detectable in a specimen is dependent on the specimen type and the dosage form, in addition to the amount of the dose that the patient took, the frequency of their dosing, and any individual patient metabolism factors as well. In general, buprenorphine may be detectable up to 7 days in urine, up to 48 hours in saliva or oral fluid, and up to 24 hours in blood. This can, of course, vary according to what dosage form is prescribed. For example, patients taking transdermal buprenorphine may have lower concentrations of drug in their body, and thus their specimens may have lower drug concentrations. Urine is considered the preferred specimen to collect for transdermal buprenorphine because of the lower drug concentrations. The urine provides the best likelihood of detecting the presence of drug, but negatives can occur for some patients in urine, even if they are compliant with the patch change instructions and adherent to that schedule. Oral fluid and blood are not considered viable options for assessing compliance with transdermal buprenorphine due to the very low drug concentrations that are expected in those specimens. Injectable buprenorphine may be detectable for an unknown period of time following drug discontinuation. However, it's also possible that a patient currently receiving injections may have negative toxicology results for buprenorphine. There's just limited information here. There are no specific studies that have investigated the use of buprenorphine injections and the length of detection in toxicology testing. The consideration with sublingual or buccal formulations is not as much the period of detection as the potential drug concentrations that can be observed in oral fluid. Because of the way these formulations are administered, patients can experience an oral depot effect from recent drug administration. High oral fluid buprenorphine concentrations may be possible for about an hour following the dose. If the patient is to be tested and they last took one of these dosage forms within an hour prior to testing, urine may provide a better picture of compliance just because of those high concentrations that may be observed in the oral fluid from that recent dose. Although we have discussed situations of higher and lower drug concentrations that may be possible following various dosage form administrations, the drug concentration of a specimen cannot be used to determine the specific dosage form used or the amount ingested. You have to consider things like time since ingestion or last use or last dose, drug interactions that may be involved, the urine concentration if we're looking at a urine specimen, the patient's liver and kidney function, and then other patient individual factors. All of these can affect the drug concentration that we would see in a specimen, which makes that correlation back to an amount ingested or a dosage form not possible. There are both benefits and limitations to evaluating the buprenorphine to norbuprenorphine ratio, which is the parent to the metabolite ratio. It's unrelated to the dose administered. It can definitely vary from patient to patient and then over time within the same patient. Drug interactions can affect the parent to metabolite ratio, since there are drug interactions that can affect CYP3A4 activity, which is the primary enzyme involved in the conversion of parent buprenorphine to the metabolite norbuprenorphine. Low metabolite concentrations could indicate drug abstinence or recent ingestion. Generally, the parent to metabolite ratio decreases over time as the drug is metabolized, but evaluating the ratio can also help identify cases of specimen tampering or adulteration, and we'll talk a little bit more about that. So when low metabolite concentrations or absence of metabolite is observed, this must be evaluated to determine if specimen tampering is likely. If the parent concentration of buprenorphine is high with low norbuprenorphine concentrations, this can indicate that drug was added directly to the specimen. AEGIS mathematically analyzes the parent to metabolite ratio in urine specimens of parent buprenorphine to the metabolite norbuprenorphine, and if the ratio is greater than 35:1, the report is flagged for the practitioner to consider possible adulteration. In these cases, a provider may want to consider an observed urine collection or an oral fluid collection if they wish to test the patient again. Both of these options allow for direct observation of the patient, which reduces the opportunity for specimen tampering. If there is a low parent buprenorphine concentration with no metabolite detected, consider the impact of some of these other things like dilute urine, whether or not the patient's receiving a transdermal formulation, because as we recall, that can result in lower drug concentrations. Maybe it's an oral fluid test where, because of the way that drug is excreted in oral fluid, we don't always expect to detect metabolite in oral fluid, or perhaps recent drug administration. So depending on the patient's circumstances, several of these factors could be impacting why we're seeing a low parent drug concentration and no metabolite detected. So this type of scenario is unlikely to be a result of tampering. When the urine is dilute, for example, this can bring down the drug concentration, and depending on how low that parent drug concentration is, the metabolite concentration could fall below the reporting threshold. As we discussed previously, transdermal drug administration also results in low drug concentrations in urine and possibly negative metabolite results. Oral fluid samples may have lower drug concentrations, of course, outside of that 1 hour post-dose window that we talked about after a buccal or a sublingual formulation, when patients can have that higher depot effect. And also, situations of recent drug administration may yield a low parent drug concentration with no metabolite detected, just depending on the timing, if metabolite hasn't had a chance to show up in the urine just yet or in the specimen. The AEGIS clinical team is available because these scenarios can be complex with multiple factors to consider, and you're weighing that determination of if we're looking at a high versus a low parent drug concentration with that absence of metabolite. So our clinical team is absolutely available to discuss those reports with you, and I will provide our contact information at the end of the presentation today. Naloxone testing may also help add context to the results. Aegis offers testing for naloxone in urine and oral fluid as an add-on test. It is not included with a profile, or it's not automatically tested with any other drug. So if testing for naloxone is desired, this must be selected separately during the ordering process in order to be tested. So before making a clinical decision based on the absence of naloxone in the specimen, just check first to make sure that it was tested if that was the intention. The period of detection in urine for naloxone is up to 3 days. In oral fluid, naloxone levels may not reach detectable levels, even with prescription compliance. So a negative oral fluid result does not necessarily point to noncompliance. Naloxone may be present following use of a combination product containing naloxone, such as Suboxone. It may also be present if a patient received emergency naloxone from a relative, friend, from law enforcement, an emergency department, whatever the case may be. Naloxone may also be an end metabolite of naloxegol or Movantik, which is a drug used to treat opioid-induced constipation. The oral bioavailability and renal excretion of naloxone differs from buprenorphine, and this partly accounts for the differences in detection with toxicology testing. The ratio of buprenorphine to naloxone cannot be used to definitively state the route of administration of a drug or characterize any misuse of a prescribed drug. In summary, let's walk through the main considerations with unexpected results. If a patient has an unexpected positive result for buprenorphine and or naloxone, do they have a current prescription or possibly an old prescription at home? Remember to consider all the dosage forms that we talked about and how some may have unexpectedly longer periods of detection. Is the patient at risk for purchasing buprenorphine on the street? Some buprenorphine prescriptions are diverted and sold on the street. This drug slowly dissociates from opioid receptors, which can offer an extended high for non-opioid dependent users, and it can also help mitigate withdrawal symptoms for those that misuse opioids. So that's a question as well if the patient is at risk for purchasing these products on the street. Has the patient received an emergency naloxone treatment if you're looking at an unexpected positive naloxone result? Are they prescribed naloxegol for opioid-induced constipation, or Movantik is the brand name for that medication? Now, on the flip side, if the sample is negative when a provider is expecting a positive result for buprenorphine or naloxone, consider the period of detection of the dosage form that's prescribed for the patient and the specimen type that's used for testing, all those different caveats that we talked about that may affect detection in a particular specimen type depending on which dosage form is prescribed. Did the patient run out of medication? When was their last dose? So thinking about that in context of expected period of detection and specimen type, did that last dose occur outside of the expected detection window for the particular scenario? If naloxone is negative, is it possible that the patient used a buprenorphine monoproduct? Or could it be that based on the difference in period of detection for buprenorphine versus naloxone, that buprenorphine is still detectable whereas naloxone is not, because those drugs have different periods of detection? This may be possible with recent noncompliance, so remember to ensure that naloxone was actually ordered for a sample before assuming negative results. Again, the Aegis clinical team is available to discuss these results, whether they are unexpectedly positive or negative, and these are the types of questions that we would ask if you give us a call and talk about results, to try to better understand the clinical picture and provide some information about whether or not the results can be clinically explained. So thank you all again for joining us today. If you have questions, you're welcome to email or call the clinical team using the contact information on your screen. If you would like to discuss patient results, a specific case, that would probably be best for you to reach out to us individually. If you have general questions and you would like to ask those now, go ahead and feel free to unmute. I'll be happy to answer those if you'd like. Okay, well, if there are no questions, we will go ahead and conclude today's webinar. Thank you all again for joining us. Thank you for your time, and I hope you all have a great day. Bye-bye.